you, Eco India, for this wonderful privilege. It's an absolute honor and privilege to present here. My topic will be on selecting the optimal patient for TAVR, and there is no way we can have this section at all without dedicating this whole section to the memory of a true mentor, a great friend of India, and RIP Alain. So the basic, I think the basic promise with which he himself started the whole idea of transcatheter heart valves, when probably he'd have initiated it 22 years back, would be that we couldn't ever discover new oceans unless you have the courage to lose sight of the shores. We are interventionalists, we have a heritage, we believe that less invasive is better. We are technology addicts, geeks, we are passionate about experimental and clinical research, we rely heavily on agility imaging, but true to our nature of being scientists, we are skeptics. So even TAVR went through this. This is called as the Gartner's hype cycle. When anything is actually given, anything, even if it's ARNI or if it's anything, SGLT2 inhibitors, it's gone through this. There's an innovation trigger. Suddenly we feel elated about the whole thing, and then we have to speak of inflated expectations. Then we realize that we have been hit. There have been some annulus injuries, some paravalvular leakage, some pacemaker implants, some strokes. Then we say, oh, there is a trough of disillusionment. Then we decide to fight back, because that's our nature, right? We are scientists, we are doctors, we are interventionalists. Then we start going down from the high risk and say, oh, we can still do it in the intermediate risk. Can we do with a better valve? Can we do with a better structure? So there is a slope of enlightenment. Finally, we reach to a plateau of productivity, where we try to temper between all of this and try to get some sort of sense into the whole picture and try to go beyond the boundaries that it offers today. It's beyond just AS. There is low risk, there is aortic regurg. So if I'm given a topic of selecting a valve selecting a patient for a TAVR procedure, it's not just putting him on the table and doing a TAVR procedure. It's a journey from an evolution to a revolution. We started off with the high risk and the extremely high risk trials, that is partner. And we realized that as we went along, we could actually sort of give it to the lower risk group and actually make our own outcomes and the patient's outcomes better. So we went for this Notion trial, which is a low risk trial, a Certavi, which we have a 5-year follow-up now, which is the intermediate risk, and we tried to make sense of it even in partner 3, which is a low risk trial, whether we can actually give it from an inoperable and an extremely high risk patient to a first line treatment, maybe for an older patient. We had our early confrontations with our interventional, non-interventional colleagues, the CV surgeons. But then eventually, as time went on, it was clearly proven from the earlier trials where we were actually doing nothing for the patient, that is medical therapy. We were definitely superior with TAVR. Then we went on to see whether is it equal to Savr, whether is it equal to Savr, and then yes, the partner 1A and the OVAL proved that we were not inferior to Savr, or maybe even superior. And now with VIV coming in, it's always better if we actually have randomized trials and registry data to show that VIV is actually better than going for a redo Savr. So that keeps a lot of options open for us. And obviously, based on this, we have the entire repertoire of the valves today. We have the newer valves, Accurate to Neo, Evolute Pro, our own MyValve. And we have come across from a simple balloon expandable and a self-expandable to actually retrievable devices like the Lotus. We have tried newer vistas for AR, for example, with valves which have hooks, which have crowns, which can actually anchor, for example, the Helio. So these are all the newer things. So when we start off by trying to decide which patient and to actually take for TAVR or Savr, we always have a heart team huddle. We have it in our institute, we have it everywhere. We try to look for whether it's just one decision making, or is it a complete team? Because someone tells us about the access, someone tells us about the kind of airway that is there, because it's a patient we are treating. It's not really just putting a valve, and it's not just machines. Of course, outside of hospital politics and finances. So choosing, of course, requires a risk course, life expectancy, in which we look at the risk-benefit ratio. We look at the comorbid conditions that the patient has, which might mandate surgery anyways, for example, and look at the estimated quality of life. And that's very important, because when we do it today, we know that we can do it. The question is, should we do it and should we not do it? If we see the kind of risk that's involved, that's clinical geriatric risk and the anticipated benefit, which is extremely important, because this is actually a quality of life analysis which is done from Cleveland, and they have seen that if you see the kind of the graph, it's mainly 53, 12 and 5. You can see that almost 70% of patients perceived that there was improvement. At least 65% actually perceived. But yes, there were actually 14% who were actually worse.
It could be because of a stroke, could be because of a TAVR or a paravalvular leak, but we are at least able to offer 65 to 70% of patients the benefit of both quality and quantity of life. Who are the ones who will not, we are clear about this, who will not benefit? So when they did an analysis of TAVI versus no TAVI, clearly the ones who are in the extremities of life. If you do it in extremis, then you've already lost, you actually missed the bus. So is it advanced CKD? You've lost time in these people. If it is chronic lung disease, which is too much dependent on oxygen, or if you have more than 2 CATS indexes of frailty, or if the patient is already too bad for this. For example, patient has got PA pressure which is high, or organic MR. It's not really going to help too much because the patient is already sick. Patient characteristics drive the choice. It's not just that I would choose for him, but I also look at what is the patient characteristic. If he's got severe valve calcification, LVOT calcification, then he would probably hook better with the Self-X. Or for example, if somebody's got a low, like a narrow QRA, sometimes maybe Self-X can actually, since it's supraannular, can actually decrease the risk of patient prosthesis mismatch. But pacemaker might be more with them. So it will all depend upon what is the patient's characteristics as well. And of course, never to forget the post-TAVR PPI, because we are actually dealing with septuagenarians, octogenarians. So you don't want a valve, to actually causing a CHP in them. So in terms of what we have come to now, the metrics have changed. When we had on the left side, when we are looking at the older population, we are looking more in terms of mortality, stroke, quality of life, and PPI if it's required or not. But then when you're looking at younger characteristics, it's extremely important. Younger patients, when we are giving these valves to, we should be very mindful because their life expectancy will be more than the durability of the valve, probably. So when that happens, you have to think about coronary access. They might require it in the future. Is it going to require a VIV in the future? And we cannot leave them with a patient prosthetic mismatch. It's going to be detrimental to them. So who gets what? Obviously, there's a multidimensional approach. We all know this. As I just mentioned, it's scores plus the kind of anatomical factors that are required for it, and a multidisciplinary team working on the whole patient. And the access involved. If it's too calcified, is transfemoral really possible without access issues? Are we going to go for a transapical? Do we have surgical backup? Or any other issues that are important? So generally, if I were to just bunch it in one basket, probably a younger age, with bicuspid valve, now I'm just going to come to that again, with a less favorable femoral axis, low coronary osteohyte less than 12, multivessel CAD, where anyway you have aortopathy or a concomitant valvulopathy that requires surgical AVR, clearly favors a surgical AVR. Whereas when a patient is going for a redo surgery at an older age, if he's frail, has got a high surgical risk, the chest is not good, he's got a porcelain aorta, chest radiation in the past, obviously, one would tend towards going to a TAVR more than Savr. So we have gone on this arrow from the right to the left when it's gone from a futile or a increased risk patient, when you have an STS risk score which is prohibitive. We have today now the novel indications where we are looking at lower risk patients with more subsets. So the options available to us broadly are this. You have a low surgical risk, you can go for a Savr. If you have intermediate risk, then you still have both the options. But if it's a high surgical risk, clearly TAVR. But then you also have an option of VIV TAVR today. And if you have an intermediate risk, this is where a lot of confusion happens, because you do not know when it's going for Savr. Suppose if you go for a biprosthetic valve, you can really actually do a redo Savr with them and then keep a VIV open later. You can go for a TAVR to start with. So all these options give us a lifetime management, which is all the options available to us now. Now, till now, it's about what is a timeline as per the age. So if you see in terms of the kind of guidelines which are there, the red ones are the EAC and the blue ones are the ACC. Clearly, if you see the cutoff, it's around 75 for EAC. Very clean, simple. EAC says you're less than 75, more than 75-year-old. While ACCHA goes for 65 to 80. If the patient has got 65 to 80 years and another 20 years, for example, for life expectancy, then they still say that you should go for a Savr. But then if it's the older ages, definitely there's a 1A indication for TAVR. So keeping all of them options again. If you go for Savr, then you go for a TAVI. The first and the third are clear. The second one is Savr and Savr again, and then you can go for a TAVI, which still keeps it open. But then one has to be mindful about the associated considerations. If there is a VIV, there's a risk of coronary obstruction unless you go for a lampoon or if you go for a basilica. So all these things come into play. And today, actually, this slide was shown by Dr. Ramdas Pai also yesterday. We have gone into a completely different domain of asymptomatic severe AS. Let's talk about that as well. BAV, other avenues at all. So till now we were at Italy. Now we have Tawa Italy, we have Kanchipuram Italy, we have Jowar Italy, Bajra Italy. And you're trying to go into expanding indications because you know that your basic Italy batter is ready. BAV. Now, this is something which we've always believed, and a lot of times with Dr. Giza in Hungary and all those who actually come down here, they've spoken well there should be a consortium in India, because that is the type of valve we're doing here today. We're getting a lot of bicuspid valves which we are trying to do, and for TAVR, I mean. And when you see in terms of the calcified or non-calcified traffic, clearly if you have a calcified traffic in them with a lot of calcification, they do worse unless you really do them well. And they also have an aortopathy. It's not just a valve, it's a combined aortopathy that we're talking about. So eventually the patient might actually go for an aortic dilatation, and you might be landing into a different realm altogether. However, if in terms of VAV aortopathy, if there's a very high surgical risk, very old age patient, or if you have a high surgical risk, TAVR is still an option. But if the patient has to go for an ascending aorta, if it is dilated and he goes for a Bental, then the surgical is obviously a much better option. Other considerations in VAV, the degree of calcification, where is the location of the raphe, how much is the calcification, how much is the SOV height. However, if we are going to have a consortium in India about it, we are going to think about how it applies to us. What are the high-risk features which needed, which preclude TAVR? What is there a need of an RCT? Yes, it should be done, but the numbers are still lesser. Which value is optimal in sizing methodology? I'm sure there are other speakers after me who will be alluding to this, but then in terms of a need of clarity, we're still not very clear about it. AR is something that we have gone into as early as 2004. We knew we had patients with larger aortic annuli, a concomitant dilatation, and they require a completely different kind of an approach. For example, you need to give a Jena valve. Now, Jena valve has got actually a docking system. This is the, you have a locator technology, and it docks well, and it allows also for a coronary access as time goes on. The German registries have proven that the amount of AR that you get is almost 96% or none. In almost none, like 0% AR in almost 96% of patients. SMART is a trial which is going on for the small annulus. So all these are the newer vistas which we can be actually looking at. How can we decrease PPM? I just said PPM can be very mortal. Yes, it can be, because unless you take it out, because this is something that we've gone into a different realm with. This is what I was talking about. This is going to be the future of TAVI. What are we going to do about the moderate AS? Because when we look at the kind of lifetime of AS, can we just give them upstream before the LV damage happens? That's the whole point. So there is a challenge in timing. Where is the sweet spot we're going to actually go in? Is it, we can't be too early, we can't be too late? I'll just take 2 minutes more, sir. Because we're talking about challenges in staging. We have the stage 1, 2, 3, and 4 where the LV damage leads to LA damage, then PH comes, and then right heart damage. We don't want to land in this. So where exactly is a sweet spot where we entertain? And this is where low and intermediate risk patients come. Because there's a whole different idea today about looking at MOLY, looking at the MRI sequences, the T1 weightage, where we look at what is called as the energy loss index, or like what we call as the patient prosthetic, the pressure recovery. So all those come into play, where we look about low and intermediate risk patients. Device technology has changed to more of regenerative material being used in the current valves. We are fighting against a surgical valve, which we know has got a longer durability. But we need to have at least 10 years of durability data to say that our valves are durable, which we do not have as yet, because we almost have a bioprosthetic failure of 3.7%. So this needs more look-see into, because we might need to go for better material when we make our valves. This is again a different realm. So we have a lot of things, when a patient, for example, has a CAD, you can have actually multiple options. You can go for both, or you can stage one or the other and place PCI before TAVR before PCI, keeping it open, supposing your coronary artery disease is not too bad. Why would you want to do a PCI? So the whole point is trying to allow for anatomical future access. We can't make somebody else's life, some other interventionist life bad tomorrow by putting in a valve now, and then he cannot access it later, for example. So these are the newer valves which actually allow passive conventional alignment. I'll skip this for the sake of time. So the point is, as I said, Jena has come now. This actually gives us better conventional alignment. One last point to touch upon is what to do after we put a valve. Because these are 70, 80-year-old people, can we really anticoagulate them? Should we give them dual antiplatelet, single antiplatelet? This is also a consideration, because bleeding risk is definitely a big consideration. So if somebody doesn't have an indication for an oral anticoagulation, it's simple not to give them any OAC. But because a single antiplatelet would do. But if they anyway have an indication for OAC, then that becomes the norm. We still have gaps. I'm sure the speakers after me and generally in life, we're going to see and answer these questions for ourselves. We're looking at bioprosthetic valve durability or failure. We're looking at halt. That is, if you have thrombosis in young people, that's not acceptable either. Can we use several protection devices, off-label today, but can we start using them more often?
and all the other diseases that I spoke about in terms of AR and low of AS. Summing it all up, this is how we would generally choose our patient. If you look all the guidelines together, if a younger patient comes in, as I said, if there's a surgical risk which is low, frailty index which is low, if the patient requires surgery anyways for any other valvulopathy or CAD, generally favors Savr. TAVR in an older age group, more than 85, if it is a high risk, if it is high sort of prohibitive risk from where we started our initial partner trials, severely frail people who are not able to take surgery and do not have too much of concomitant other valvulopathies or AR, TAVR would definitely be more favored. As per the guidelines, the ACCHA clearly puts it as less than like 50 years of age there, 65 years of age there, and if you have a life expectancy of more than 20, Savr is better. That's a 1A indication. And if it is more than 80, I'm done on the last slide. And 65 to 80 is always been a little bit of a shared decision making with the patient and the surgeon. So the only thing is the last one I would want to say, the only thing that ACC and AHA and ESA differ is in the age. That is 75 is clear for ASC, less than 75, more than 75, and for the ACCHA 65 years and a life expectancy of 20 goes for Savr. This is the promise that we have from a tissue valve to a regenerative medicine. These are all the newer valves which are going to be in the vistas in the future, which I'll let my future speakers talk about. Thank you so much.
Nice presentation. We'll take questions
Sure.
after all these things. So let's move on with shortage of time. Let's move on to the next speaker. May I invite Dr. Hari Chaleki to speak upon imaging for TAVR intra and post procedure.